Good afternoon. My name is Leah Dyson, and I'll be facilitating today's gathering. Thank you for joining us for the SAMHSA Center for Mental Health Services Maternal Mental Health Learning Collaborative webinar. Before we begin, I'd like to review some housekeeping items. Since we may have a high number of participants on the call, all participant lines will be muted. If you have questions or comments, please submit them at any time by using the Q&A feature. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. Closed captioning is also available. You can go to the ellipse at the bottom of the screen below to show more captions, change their size, or use the icon beside the closed caption notation at the bottom of your screen. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at SAMHSA, S-A-M-H-S-A, state TA, all one word, at jbsinternational, all one word.com. Lastly, this is a recorded event and your participation grants consent to be recorded. The recorded webinar and slide deck will be available and sent to all participants at a later date. Next slide, please. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, CMHS, the Substance Abuse and Mental Health Services Administration, SAMHSA, or the U.S. Department of Health and Human Services, HHS. Next slide, please. As people continue to join today, please take a minute to say hello by telling us your name, your state and/or affiliation, and any other related information you would like to share in the chat. We'll try to interact in that chat as best we can. Healthy multitasking. Next slide, please. I'm going to briefly provide a plan for our time together today. We've opened and covered some housekeeping already. We will continue shortly with a bit of information about the Learning Collaborative experience, and we will then have some time to hear briefly from SAMHSA, who's been so inspired and so impressed by all states and territories' work on maternal mental health. When our SAMHSA leadership joins, we may shift, so we thank you all in advance for your flexibility when we pause to incorporate their important remarks. We will then hear about many of the states that participated in our Learning Collaborative, including priority objectives, key progress, and lessons learned. While states are presenting, please note any questions or comments you may have. We will have time for a question and answer period, and we do hope to hear about the connections and opportunities you see, as well as your experience within your states, your territories, your agencies, as you address maternal mental health. And seeing all of those folks pop in the chat, thank you so much. Great to see you all here. We'll end our event with a few closing comments and ask for your feedback about this webinar. I'll now take the opportunity to provide a brief overview of the Maternal Mental Health Learning Collaborative, its objectives, focus, participants, activities, and select themes. Next slide, please. The Learning Collaborative had 4 main objectives. First, to support participants in gaining knowledge and best practices for state mental health agencies to promote and support maternal mental health. Second, to highlight common barriers and potential solutions across states and territories. And third, to apply lessons learned and share promising approaches to apply to participant case challenges. Fourth, finally, to document practices, processes, and insights to expand peer learning for dissemination to all mental health block grant grantees. Next slide, please. Maternal mental health. The journey here and to this webinar began with SAMHSA's commendable support of increased focus on comprehensive maternal mental health and recent launch of SAMHSA's Joint Task Force on Maternal Mental Health. Supporting maternal mental well-being strengthens not only mothers, parents, and women, but also their families and their communities, as we all know. SAMHSA has prioritized addressing maternal mental health conditions and co-occurring substance use disorders with a particular focus on mental health equity and trauma-informed practices. As you all know, state mental health agencies do absolutely vital work in this area, but designing and sustaining a cooperative approach brings challenges, and therefore collaborating closely with those who have a common vision is invaluable. Hence, this particular Maternal Mental Health Learning Collaborative was, shall we say, born. Next slide, please. Over the course of winter 2023 and this year 2024, SAMHSA sent invitations to all states and territories to assess interest in participating in this learning collaborative. In the early spring of 2024, SAMHSA selected 8 states and territories to participate here: Connecticut, Iowa, Marshall Islands, Montana, New Jersey, New York, Utah, and Washington State. As you see on this fine map here, well represented across the country and territories. Next slide, please. Each participating learning collaborative team had core team members, 2, before we get into the SWOT analysis, spanning both maternal health and behavioral health, including mental health and substance use, totaling 16 participants across the state teams. The collaboratives then worked together over the course of 6 to 7 months, including 1 kickoff meeting and 5 monthly web meetings. The collaborative kickoff was a 1-day in-person session for all selected teams of 2 at SAMHSA headquarters in March of this year. In advance of this event, states and territories were asked to conduct a SWOT analysis, as you see here, which covers strengths, weaknesses, opportunities, threats of maternal mental health supports and services. Findings would then be presented and brainstormed with the full group when together. States and territories were also asked to identify an initial case challenge or area of focus relevant to local maternal mental health needs. For many, this was a priority area that rose to the top when completing a SWOT. We'll talk about the case challenge more in a moment. For the SWOT, the teams were tasked to think about internal strengths that could be used to remediate their challenge or address their area of focus, such as leveraging existing internal resources, processes, or partnerships. Internal weaknesses that may be a barrier to addressing challenges, such as staff training and gaps. External opportunities that could help support areas of focus, such as funding opportunities or aligning efforts with external factors. And external threats that could be a barrier to progress, such as fiscal or political trends or other uncertainties. So, for example, if a state is struggling to engage a wide range of partners in targeted and tailored maternal health services, and one of the biggest impediments is confusion by providers on how to specifically incorporate maternal mental health and how it's important to whole person care, one internal strength in a SWOT may be an already developed set of maternal mental health educational materials. For example, for primary care providers, an internal weakness might be staff training and availability, especially of those comfortable and developed to work with and engage providers of different initial perspectives. An internal or external opportunity might be training on provider communications and engagement for all types and levels of staff who support maternal mental health services. And an external threat might be availability and applicability of funding sources for a concentration on provider engagement and education and/or provider resistance. Next slide, please. With regard to that case challenge, states and territories were asked to identify an area of focus relevant to maternal mental health, which they concentrated on throughout the course of the Learning Collaborative. After finalization of this case challenge at the kickoff, each team used the remainder of the Learning Collaborative, that is, our activities, presentations, team discussions, lessons and resources from participating external subject matter experts to address this focus. We would devote time each monthly meeting for states to share updates on addressing their case challenge. Throughout it all, it was important to remember that case challenges be realistic, something that might stretch a state or territory, but something on which accomplishment could also be felt in our short span of time together. The amazing Learning Collaborative states will describe a priority objective from their area of focus, as well as progress and lessons learned in a bit. But for now, the general structure of a case challenge included the pieces on this slide. The case challenge overview included background, historical context, and other factors to help understand challenges teams were facing. Number 2, relevant data for the case challenge included dates, evaluation outcomes, measures, etc., that highlight the importance of areas of focus and/or potential strategies for improvement. It included key partners and considerations for them: active, who is currently at the table; inactive, who used to be but may no longer be at the table; and potential, who is not at the table but should be. Defining success was also incorporated. What does a successful outcome for the case challenge look like? And lastly, SMART goals were to consider what's specific, measurable, achievable, relevant, time-bound for goals and objectives. Next slide, please. Beginning with the kickoff meeting in March, the SWOT analyses, the case challenge brainstorming, some themes rose to the surface related to addressing maternal mental health across all states and territories. The collaborative continued to discuss these throughout our time together, even though states and territories were at varying places in their work. These 10 themes were of sufficient note. Solutioning upstream and building prevention into maternal mental health models is key. Equity and social and structural determinants of health must be considered and incorporated in all approaches. Messaging to persons and populations in need of maternal mental health services needs to be tailored and/or delivered by trusted sources. Peer support services are vital to outreach and engagement, as is the standardization of work with peers, for example, standards of practice, credentialing. There are multiple funding streams available for maternal mental health work, which can be both wonderful, beautiful, and complicated. Clarity and guidance on what within critical maternal mental health services can be reimbursed by Medicaid is beneficial, as well as state Medicaid agency partnerships. Maternal mental health referrals and screenings require appropriate time, attention, tested tools, and billing opportunities. People doing this work are wearing multiple hats and carry multiple responsibilities, as I'm sure many of you are feeling in particular, and sometimes too many. Maternal mental health crisis services, including suicide prevention, are of particular importance, and leveraging existing systems to apply to maternal mental health would be beneficial. And last but not least, it is crucial to include and educate primary care as partners in maternal mental health and vice versa. Next slide, please. For our monthly sessions, our Learning Collaborative featured a number of esteemed, committed, and most importantly, engaging external subject matter experts on a variety of key topics. As you'll see here, we explored stigma in maternal mental health and strategies for engagement with talented licensed clinical social worker Nicole Clark of Nicole Clark Consulting. Nicole is a licensed social worker where she partners with mission-aligned Black, Indigenous, people of color-centered, women-led, and allied organizations whose work supports the lived experience and advancement of women, girls, femmes, and gender-expansive youth of color. Using a reproductive, justice-informed, and intersectional approach, Nicole leads and partners with and consults on projects related to participatory research, program design, strategic planning, and culturally responsive and equitable evaluation. Next, the incomparable Kay Matthews graced us with innovative and participatory approaches to addressing maternal mental health access. Kay is the founder and CEO of the Shades of Blue project and concentrated her presentation on Shades of Blue's inclusive Inspire method of engagement and access. The expert, Dr. Dana Meany-Delman and Tamara Lewis-Johnson, educated us on the implementation of evidence-based practices and dissemination of research findings. Dr. Meany-Delman is the chief of the Infant Outcomes Monitoring, Treatment, and Prevention branch in the Division of Birth Defects and Infant Disorders at the National Center for Birth Defects and Developmental Disabilities at the CDC, the Centers for Disease Control and Prevention, and Tamara is the program director of the Women's Mental Health Research Program for the Office of Disparities Research and Workforce Diversity at the National Institutes for Mental Health and the National Institutes of Health. Next, maternal mental health champions and steadfast federal collaborators, Dawn Levinson, Diane Tanman, along with psychiatrist expert Dr. Nancy Byatt, shared with us federally sponsored and state implemented programs to strengthen and integrate the maternal and behavioral workforce. Dawn is the Deputy Director of the Division of Healthy Start and Perinatal Services at the Maternal and Child Health Bureau of the Health Resources and Services Administration, aka HRSA, and Diane is a public health analyst in the division as well. Dr. Byatt is a professor with tenure of psychiatry, OBGYN, and population and quantitative health sciences at UMass Chan Medical School and developed the Massachusetts Child Psychiatry Access Program for moms. And last, but absolutely not least, Centers for Medicare and Medicaid Services partners Ellen Marie Whelan, Linda Streitfeld, and Kristen Zickerman, the Chief Population Health Officer of the Division of Health Innovation and Integration, and the lead for the Maternal of Infant Health Initiative, respectively, discussed funding considerations and Medicaid partnership opportunities for maternal mental health services. A wide and vast and in-depth, deep experience with our guest speakers throughout the collaborative. We thank them so much. Next slide, please. Much as we talked about common general themes a few slides earlier, these next 3 slides will touch upon considerations, themes, strategic actions that were discussed during our monthly Learning Collaborative sessions. This first slide touches upon engagement and access, which are inextricably linked. In partnership with our external experts in conversation across collaborative members, we learned that intersecting forms of discrimination and stigma exist, and that bias is important to be addressed at all levels. Understand and respecting experiences before and during care, as opposed to only looking toward evaluation after care, is incredibly important. Implementing, coordinating with, and/or routinely evaluating wraparound services is critical. Creating advisory boards, committees, etc., including lived or living experience, is of the utmost value and importance. Partnering with and educating trusted community-based organizations or leaders for community-driven and informed solutions is important in our work on maternal mental health. And maternal health includes mental health, and mental health includes maternal health, something that we know, but incredibly important to constantly drive home. Next slide, please. When we talked about evidence and dissemination, we discussed that evaluating practices and practicality in the context of the social ecological model is valuable. Encouraging and supporting coordinated public health investments in behavioral health, for example, the CDC's Behavioral Health Coordinating Unit and the CDC Mental Health Strategy, is important federal strategy. Supporting clinical networks and research, for example, MatLink, the Improve Initiative, also of CDC, to develop an evidence base, incredibly important as well. Funding opportunities through specific women's mental health programs, for example, the National Institutes of Mental Health's interventions research and services and screening research is important. Using data to inform recommendations and standards of care is invaluable. And developing and sharing tools, trainings, guidance, and resources will only strengthen the field beyond those concentrating, developing, and doing it. Next slide, please. Then finally, our last 2 sessions focused on both workforce and partnership, and we covered integration of behavioral health into both whole person primary care and the full continuum of maternity care. For example, health before pregnancy, prenatal care, childbirth, postpartum, ongoing maternal and pediatric care, and that is critical. State maternal health task forces and Medicaid agencies can and should be maternal mental health partners and resources, and access to complementary state TA exists. For example, the CMS TEMA model. Different grant programs can and should collaborate with one another within states and regions. For example, the Maternal Mental Health Substance Use Disorder or Maternal Health Innovation grant programs. We talked about a number of different funding streams in our overarching and key themes, and important to collaborate as we can, appropriately and allowably so. Investments are important in not just maternal mental health workforce training, but also in intentional recruiting and workforce diversity efforts. Not an exhaustive list, but certainly a comprehensive one, and some of the high-hitting themes and lessons learned, strategic actions we talked about during our monthly sessions with one another. Next slide, please. Now for the Learning Collaborative's hardworking and wonderful state participants. We have 7 to hear about, so we kindly ask that presenters, you do keep your time. I will say before we start, please note that the Montana and Marshall Islands teams will not be presenting today, Though if we do have, I'm kind of sort of looking through this chat, representatives here from those amazing locations, hello and welcome. I will humbly be sharing some brief information on Montana's behalf, and we encourage you to ask any questions you may have for our states or territories, Montana and Marshall Islands included, and we can then pass them on and connect you. Almost up, the incredible Iowa team, but first, please remember when you are through Iowa, you can toss the mic directly on over to Connecticut, and so on for our other teams as well, so we do not break up the meeting flow. And now I will say, Iowa, take it away.
Thanks, Leah. Nice to see all of your faces. Bridget is not able to join us today. She is actually in one of our collaborative efforts that I'll reference during this presentation, but she's actually meeting with one of our universities in the state of Iowa focused on the maternal health and perinatal mental health as it relates to women who use amphetamines. So that is like a day-long project, and there's a lot of people involved in that. It's a one of our valiant efforts that have come about throughout this process. So I'll talk about that in a second, but that is where Bridget is. And I'm Jennifer Robertson Hill. I serve as a project director for a PIPIC grant. If any of you are familiar with that term, it stands for Promoting the Integration of Primary and Behavioral Health Care, and that's a Center for Mental Health Services grant. And so that's why I was asked to step into this part of the process to focus on operation of health activities for women. Next slide. Can you all hear me okay? My mouse is scrolling in a circle and I'm like, I don't know what that means. Just as a little bit of background for this presentation. So Iowa, I work at Health and Human Services, which is the SSA that oversees substance use and mental health. But that wasn't always the case. Public health was separated from human services, so mental health and substance use were separate. Over the last 2 years, those departments have aligned their efforts. And as a result, the space where Medicaid exists, substance use work, mental health work, and maternal health work were in separate spaces. So over the last 2 years, those efforts to align the two state agencies have really resulted in a lot of collaborative work. So this opportunity kind of came along at just the right time when we were starting to just figure out who was who and where. Because when you work in separate spaces physically, you do end up in silos. So that would be probably the biggest lesson learned for us is collaborative efforts are definitely necessary, but it's definitely a balance because you have to continue work and there's always more work to do when you get into each other's spaces. So that's been something that we've learned as we started this process. So our case challenge focus was specific to maternal mental health and substance use. So our data reflected higher rates of postpartum depression in Iowa than the national average, higher rates of women of childbearing age reporting binge drinking and misuse as well. For our access to care piece, not only are we 44th out of 50 states for mental health professional access, but as of like last year, we were 50th for the access to OBGYN services as well. So I think I had, it says Zoom's not responding for a second. But over the last 7 years, a lot of our critical access centers, hospitals have taken over OB services. Most people in Iowa have to travel an hour to an hour and a half for labor and delivery. So that has been a significant challenge, is not just our mental health and substance use services access, but as well as OB access as well. So our choice was to focus on postpartum mental health. We have statistics and data in Iowa that identifies a significant increase in both overdose and suicide deaths in the postpartum period. And so that's why we chose to focus in that space. As a result of those efforts and the work that we've done in this collaborative We have developed, as I mentioned, an interagency collaboration. And so right now we are both simultaneously participating in a build out of state strategic plans on both the maternal health side as well as behavioral health. And that has led to a greater alignment of efforts. And most of the work that the maternal health space oversees is really dedicated to their Title 5 and Title 10 clinics. And most of our space, a lot of our work is dedicated to our block grant funded behavioral health providers. And so what we've really done, thanks Leah for changing the slide. Mostly of what we've done, our objective was to develop this shared responsibility between both spaces within our.
I think we may have lost Jennifer. Jennifer, if you can hear us, sorry about that. I'll humbly read off of here in your hopefully temporary absence, and then we'll move on. But again, folks and audience, if any questions for our presenters, please feel free to hold on to them, type them into Q&A either now or when you have the moment to, and we'll be sure to get them to Jennifer and the Iowa team. But as I think Jennifer was sharing, their priority objective was to develop this shared responsibility between maternal health and behavioral health within the Iowa Department of Health and Human Services. Their progress has been incredible. Members of the divisions, excellent. Jennifer, are you back?
Yeah.
Great.
The whole time I was presenting, it was gray. The screen was gray. And I was like, it's going to kick me out. I know something bad's going to happen. But I
Well,
was
we're
like, I'm
here
just
for
going to
your
keep going.
progress.
Yeah. And I was really close to being done
Great.
anyways. But I think that, the biggest lesson learned for us is that like sometimes when you put meetings on a schedule, just to put meetings on a schedule, it can sometimes be the dead space, dead time. And you just don't feel like that, meeting is necessary to always have on there, but it's really an ebb and flow with the relationships between separate spaces because you're simultaneously doing your own work as well as trying to do the work in your shared space. And so it's a balancing act. And that seems kind of like mundane to kind of describe that as like a lesson learned or progress, but consistent existence into each other's spaces is very difficult because we all have our own priorities. We have our funded work, we have these spaces, but until you have like a shared position between, which I've heard of some states that do during this collaborative, and I'm like, I wish we could have that. So that's on my list. But until you have somebody to kind of essentially hold the responsibility of that shared space and keep that progress and work going, you have to keep at it in the best way that you can until you can get to a space where you have someone to lead the effort. So that's it. Thanks, Leah. And on to Connecticut.
Awesome. Thank you so much. And good afternoon or good morning or good evening, wherever you all are. My name is Bridget Aliaga, and I'm joined by my coworker, Rebecca Peterson, and we're here representing the Women's Services Division of the Connecticut Department of Mental Health and Addiction Services. Our department is primarily responsible for overseeing a variety of women-specific substance use treatment and recovery outpatient, residential programs, recovery support programs across the whole state, including those specific to pregnant and parenting women and birthing people. So this topic of maternal mental health and wellness is incredibly important to us and also very pertinent to our service population. So next slide. Thank you. So here in Connecticut, our data is telling a story of health inequities and disparities that are impacting our Black and Hispanic communities who compose nearly a third of our demographic. We here in Connecticut actually have the highest level of income inequality in the nation. We also have disproportionate pregnancy-related deaths among our Black mothers and birthing people. And we also have unfortunate reports of discrimination or harassment because of race, ethnicity, or culture, both before pregnancy and during pregnancy. So in wanting to support those most affected by this, so our Black and Hispanic communities, who are also among the least likely to receive mental and behavioral health treatment support, we wanted to utilize our strengths in media development to create a culturally informed campaign that would help to empower Black and Hispanic pregnant and postpartum women and birthing people to engage in behavioral and mental health supports and to also hopefully increase their confidence in discrimination self-advocacy. So our division has had a really great community response to informational animation videos that we've created on other topics like CAPTA and family care plans. We also made ones on substance use in pregnancy, secure storage of medications. And so we really felt that we could effectively create an impactful video, but we're really looking and seeking support and guidance on the culturally informed piece through this learning collaborative specifically. So next slide. Thank you. So originally we had thought to partner with 1 to 2 larger organizations who could then help to connect us to a pool of people outside of our usual reach. But ultimately, as a result of this learning collaborative, we were prompted to create an advisory group consisting of Black and Hispanic women and birthing people within our own continuum of care, as well as other state partnerships that have had their own lived experience of being pregnant and parenting, as well as the professional experience of working directly with these communities. So we recently had our first meeting to start discussing themes and messaging, and 2 items came up for both groups. So the first was the lack of trust in providers and systems, particularly due to the historical context of medical experimentation. And also the importance of prevention messaging. So one thing that the group kept saying over and over again was, you don't know what you don't know, and the importance of starting at baseline information, including the fact that public insurance can cover most of these services. So they said so often folks in their community acknowledge that they do need some level of support or some level of care for what they're experiencing, but automatically assume that they can't afford it because they don't understand their insurance coverage. And typically when they do go and get care, it's when they're in crisis and they have to go to the hospital. So really reinforcing the concept of prevention messaging in this work and this future video that we're looking to develop. And then finally, they also said the actual words mental health can be an immediate off switch for folks in the community. So really leading with symptoms like, are you pregnant and having unsettling thoughts, or are you feeling sad, but you're not sure why? And really making the campaign more symptom and person centered versus centered around the actual concept of this is mental health. Was a huge learning piece. And ultimately our goal is to have a video created by the end of the fall, but we still have some more work to do, and are excited to have been able to establish this advisory group to support us in doing the work. So thank you for your time, and I'll pass it off to New Jersey.
Hello, everyone. I'm Suzanne Boris, and I'm an assistant director at the New Jersey Division of Mental Health and Addiction Services, and we are located under the Department of Human Services, which is the largest state department in New Jersey. Chris is our women's coordinator, and we work very closely together. My office specifically manages planning, research, evaluation, prevention, and we are responsible for bringing various evidence-based practices to the state and researching them and conducting various evaluations. So, and as I said, Chris is our women's coordinator. She works on our block grant. She's responsible for our women's set aside and is very involved in all the various women's initiatives we have going on in the state. Okay, next slide. So our case challenge was, 1, to focus on access to recovery support services for pregnant and postpartum persons with SUD and mental health issues is limited. So we wanted to improve access to recovery by reducing barriers to care for pregnant people with substance use and mental health issues by expanding our current prenatal pathway infrastructure, which is managed by our Department of Children and Families. And we are using our maternal wraparound program, working closely with them to connecting it into our statewide Connecting New Jersey system, which is a single point of entry for pregnant people to access services. Then we are focused on overdose risks decrease if services offer recovery supports for pregnant and postpartum persons with SUD and mental health issues. We have the 4th highest maternal mortality rate in the country. So improving maternal and child health is a major initiative of our First Lady, Tammy Murphy. And we anticipate decreasing relapse overdose risk, since the most vulnerable period for postpartum persons for relapse or overdose is from day 43 to 100 days. So by building on the existing prenatal pathway to include access to our MRAP program prenatally, recovery support services can help to improve maternal child health outcomes. And our third challenge was the existing prenatal pathway services can be strengthened to include recovery supports up to 1 year after the birth event. So our maternal wraparound program does indeed provide peer recovery supports and intensive case management from pregnancy up to 1 year after the birth event. And I'm going to now turn it over to Chris, who could tell you a little more.
Hi. So as Suzanne said, our priority objective is to build the prenatal pathway for pregnant persons with substance use disorder and mental health issues by adding the maternal wraparound into the Connecting New Jersey system. So we aim to increase referrals to reach more pregnant people across the state, which we hope will significantly reduce barriers to care by reaching more pregnant people. So our progress to date, currently there's an electronic form in our New Jersey Connecting New Jersey system that lists supports, resources, and services, and there's separate categories for pregnancy and postpartum care, for substance use, and for mental health services. We worked closely with our Department of Children and Families, who really oversee the Connecting New Jersey system. And because Suzanne and myself and our sister departments of health, departments of children and families, we are all participating in SAMHSA's National Center on Substance Abuse and Child Welfare. We already have a state core team that we've identified maternal mental health and SUD as a priority area. So we presented to our recent core team meeting with our state partners, and everybody is on board about this plan. And so it's been approved, and there will be an automatic referral built into the Connecting New Jersey system. Lesson learned. So, you know, this is state government. System and process change involves multiple planning. It takes time. But we anticipate the start date to be somewhere after the first of the year. And I had a conversation yesterday with the Department of Children and Families, and the process is moving forward. So hopefully we'll meet our target date. And I'm going to turn over the presentation to our neighboring state, the great state of New York.
Thank you, Chris. Bonnie, before you jump in, so sorry to do this, but halfway through our amazing presentations, we want to take the opportunity, now that we have Dr. Nima Sheikh with us, the Senior Medical Advisor and Associate Administrator for Women's Services from CMHS at SAMHSA, to give a few remarks, words, I think, of some inspiration and also thanks. Nima, in the interest of not breaking things up too much, we had a beautiful and illustrious biography for you, but I will just turn it over to you to say a few words.
Thank you so much, Lee, and thank you so much to everyone. I'm so sorry I had a last minute conflict that I couldn't come at the beginning. So I'm sorry to have missed that, but I just, from me and all of us at SAMHSA, just really want to say a heartfelt thank you for your participation in this learning community and all of the hard work that you all have put in. It's just incredible to see, you know, how far you all have come from the initial concerns and problems that you mentioned in your case challenges and SWATs and the solutions that you all are working towards. It is just such a priority for the administration, kind of across the board. There's so many federal agencies doing this work. It's a priority for Secretary Becerra's office. It's just, and working with states is really key for us, and we want to continue this work. So I think most importantly, we want to make sure that you all know this is not a goodbye. We're going to be circling back to you all. We're going to be looking at the learnings of this learning community and socializing them and connecting them to other learning communities that are being done in this space. I know that we've also connected you with the CMS learning community, so I hope some of you were able to take advantage of that. But we want to do more things like that and make sure that you are connected across the department. Also in 2026, we're looking at putting together a governor's report for that will come from states, of course, that will go to Congress through our maternal mental health task force. And so we will absolutely be circling back to you all to discuss, whether that's in the listening session forum or RFI or meetings with you all to talk through what could be helpful to put in the governor's report and get your feedback. However, that doesn't mean we won't be circling back in 2025. We're really focusing on implementation of the maternal mental health strategy, the recommendations that are in the strategy. And we think so much of what you've outlined aligns with implementation of the strategy and the recommendations. So we're going to be working with governor's offices, working with other entities within states on this topic throughout the year. So hopefully more to come. And we're just really, really excited about the progress that you all have made and really wanted to share a heartfelt thank you. Let's pass it back to you, Leah.
Thanks so much, Nemo. We'll be sure to post that bio somewhere. It's a good and impressive one. But we'll turn it back over. Bonnie, thank you for your flexibility and turn it back over to you.
Thank you, Leah. Good afternoon, everyone. My name's Bonnie Catlin, and I serve as the Director for Strategic Clinical Solutions at the New York State Office of Mental Health. Dr. Audrey Azero Trevino sends her regrets today. Unfortunately, she had a conflict that she had to attend, so she sends her regrets and me in her stead. Next slide, please. And in New York, the three contextual factors that motivated our intentional focus include the clear disparities by race, ethnicity, and socioeconomic status that are apparent when examining the impact of mental health issues in birthing persons, and that this needs to be remediated. The need to increase outreach, engagement, and the availability and the access to culturally responsive treatment and supports for birthing persons are absolutely necessary in New York State. And in New York State, we remain committed to the work required to improve conditions for birthing persons. New York aims to build upon the work of the current maternal mental health work group and the lessons learned in this collaborative. Based on this information, our case challenge is how does New York ensure effective, culturally responsive, and accessible outreach, screening, identification, and treatment strategies for birthing persons and their social connections, as well as promote more robustly prevention and outreach strategies for underrepresented and vulnerable subpopulations in New York State who are disproportionately impacted by maternal mental health disorders in the prenatal and postpartum phase. Next slide, please. Our priority objective is to develop a public awareness, education, outreach campaign for those birthing persons who are at risk for developing mental health disorders, particularly for those populations who are disproportionately impacted by maternal mental health disorders. Our progress thus far is we've increased our organizational focus on maternal mental health, and we've had the ability to continue to advocate for resources. One of our recent accomplishments is we've obtained approval to add a dedicated maternal mental health position at the Office of Mental Health. The vision is this position will serve as our interagency and cross-systems collaborator, because as you can imagine, New York State has multiple state agencies, all of which are doing work in the maternal mental health realm. So we want to make sure that we continue to develop our strategy and our cross collaborations, and we're not duplicating services. So our lessons learned, of course, we are very proud of the strong foundation and the work that we've done this far around maternal mental health. However, there are multiple synergies in several of our current initiatives, including Healthy Steps, our New York State Trauma-Informed Network and Resource Center, our OMH Wellness and Public Awareness campaign, and our Project Teach program. So our next steps are really to create a unified vision and strategy for the maternal mental health work that needs to be accomplished in New York State. Next slide, please. Oh, and thank you. And I'd like to turn it to my colleagues in Utah.
Thank you, Bonnie. Hello, everyone. My name is Jade Chavez. I work for the Utah Department of Health and Human Services in the Office of Maternal and Child Health as the Maternal Mental Health Program Specialist. I am presenting alongside my colleague today, Leah Colburn, who is a Program Administrator in the Office of Substance Use and Mental Health. Next slide, please. In Utah, our maternal mental health efforts were formalized in 2018 in the Office of Maternal and Child Health. However, gaps have remained in these coordinated efforts across all system providers. Our focus with this learning collaborative has been to lean into the coordination of efforts, as all systems have a role in advancing maternal mental health to elicit positive outcomes for the populations they serve. The first challenge of focus was the health insurance landscape in Utah, and a major win for Utah has been the extension of postpartum Medicaid coverage to 12 months postpartum, which went into effect at the beginning of this year. Using this extension as an opportunity, we prioritized establishing our relationship with Medicaid, which now resides in the same division as Leah's office, and we plan to expand our efforts to the private sector. Screening has also been an ongoing focus in the healthcare system and has become an increasing focus in pediatric clinics in Utah this year. However, there remains a gap in next steps following screening. Data from Utah's Pregnancy Risk Assessment Monitoring System indicates that 42% of Utah women who were unable to get needed treatment reported that they didn't know where to go to get services. We focused a lot of our efforts in building referral systems and educating the public and providers about Utah's Maternal Mental Health Referral Network, which is a statewide online directory that currently lists healthcare providers throughout Utah who specialize in treating mental health issues during and after pregnancy. These efforts focused on referral pathways will probably remain a top priority into next year as we are working with our local mental health authorities to ensure that those referral systems are strong. Finally, while we found that while collaboration is a key focus in Utah, community-driven and system-driven work has not always been intentionally focused on coordination, which has created silos in care and impact within communities, and this continues to be a challenge that we are navigating. Next slide, please.
Thank you, Jade. For this section, we focused our objective priority on increasing partnerships by 2 agencies. In retrospect, we believed that this would have been challenging, thus only attempting to engage 2 additional agencies. However, what we have found over the course of this learning collaborative is through the intentional partnership between my office and Jade's office, we've actually been able to engage many more agencies. Regarding our progress, we have purposely sought out any group that we have heard was doing work in the maternal mental health space. We were intentional in exploring and engaging both the adult service providers as well as the early childhood providers as part of addressing perinatal mental health. We've been able to engage with the pediatric behavioral health learning collaborative, a quality improvement learning collaborative, focusing on screening, infant and early childhood mental health providers, substance use residential treatment programs, homeless service providers, our local mental health authorities, and peer support providers. Through the course of this learning collaborative, we really learned to get out of your silo. When an agency is able to identify that this work matters as it associates with their service population, they're really willing to engage. Working through opportunities to break down communication barriers and really break down those previously held beliefs of my client versus your client. We really encourage folks to slow down and be intentional about the goal when it comes to addressing maternal mental health and establishing strong, long-lasting partnerships and collaborations. And now we'll hear from our team from our Washington team.
Good afternoon, everyone. We are the Washington State team, and my name is Teresa Eltrich. I am the Perinatal Mental Health Program Manager here at the Healthcare Authority, which is also referred to as the HCA, and I work in the Clinical Quality and Care Transformations Division. And the Healthcare Authority, just for the information for the folks here, is the largest purchaser of healthcare in the state of Washington. We lead their effort on transforming healthcare through programs and initiatives that focus on the administration of Apple Health or Medicaid and behavioral health activities. We utilize data to inform decisions, and we work in collaboration with local communities, ensuring that Washington residents can have access to better health and better health care. And I'll let Christine introduce herself.
And hello, I'm Christine Mickelson. I am a supervisor in the prenatal through 25 section at the Division of Behavioral Health and Recovery at Healthcare Authority. I want to share that this has been such a great experience for us. While Teresa and I are both at Healthcare Authority, we're in two different divisions. So participating in this learning collaborative has given us an opportunity to connect and build partnerships and communication pathways to move the perinatal mental health work forward. As we went through the activities, next slide, please. As we went through the many activities that Leah talked about at the beginning of this webinar, that really gave us a chance to look at and examine the current state of perinatal mental health services and supports in Washington. Three areas of focus really began to develop for us. First, that there's a general lack of awareness of issues related to perinatal mental health in our state. And this is adding to stigma, a lack of care, and provider awareness of the importance of perinatal mental health services and supports. Also, that access to care issues for perinatal mental health is creating barriers for connections and access to treatment. Additionally, perinatal mental health work in our state is often occurring in silos, both internally and with sister agencies. And so we determined our goal for our time in the Learning Collaborative was to focus on caring for the perinatal population by working to improve awareness of perinatal mental health, identify needs, and collaborate internally and externally to improve outcomes and increase access to care. Next slide, please.
So with our objectives, progress, and lessons learned, Washington, the priority objective was to improve perinatal mental health awareness in our state. And with the progress, we found that we were actually able to accomplish quite a few different things, and that has set us on a really interesting path as far as different parties and partnerships that we maybe weren't expecting to be as interested, or that were more interested than we may have thought. So with some of the progress that we had, Washington proclaimed May as Maternal Mental Health Awareness Month, and that actually led to multiple achievements in improving awareness across the state. Along with the Awareness Month, the Healthcare Authority also hosted a roundtable event with the governor. The governor actually requested it once he signed off on the proclamation, which was wonderful. This roundtable was an opportunity in a small group to discuss barriers to care, issues and concerns, and included a variety of different providers, including tribal voice and lived experience as well. Along with that, we were able to have a robust mental health, maternal mental health social media campaign, and it was aimed at engaging providers and individuals that may be pregnant or postpartum. Along with that, we have gone on to create a perinatal mental health communications plan that has focused on improving awareness across the state and has been able to really focus on educational resources, opportunities, and social media engagement, and increased awareness about Apple Health and Medicaid resources. And lastly, something that we're also very excited about is, along with this, being able to really look at exploring the data as it pertains to Apple Health and perinatal populations in Washington, with the focus on the access to care for perinatal mental health. So some of the lessons that we learned, really aligning with a lot of the other states and their feedback, has really been that that there have been a lot of positive interests and engagements, both across agencies and with partners, both like Christine Mickelson mentioned internally as we're in different divisions, but then also externally. So that has been a really wonderful lesson that we've learned to really reduce working in silos. And then moving forward, we also are understanding that there needs to be ongoing collaboration and conversation, and sharing more of the data and research, and developing, it's just going to support developing awareness and resources across the state. And with that, we will go ahead and hand it over to Leah, who is going to share some information about the Montana team.
Thank you so much, Teresa and Christine. For the Montana team, as Teresa mentioned, and as I mentioned at the beginning of the webinar, I have the honor of presenting some brief information on their behalf. And I humbly present it, as I very much am not our incredible experts in Montana, but they so well put together some information for us to share. This is on behalf of Nikki Campbell, who is in the Behavioral Health and Developmental Disabilities Division in the state of Montana, as well as Amanda Odell, her division mate. Next slide, please. Nikki and Amanda worked hard to develop and consider a case challenge that is focused on supporting treatment facilities in exploring expanded reimbursement and funding opportunities. Some of the contextual factors for this is that in the state of Montana, Medicaid coverage for medications can be limited, or potentially other places as well. Employment gaps and pauses can cause reliance on facilities for essential baby items. And funding is not expanded to fully cover childcare needs and additional resources that support birthing persons, those who have just birthed children's return to the community. Next slide, please. Priority objective, progress, and lesson learned for Montana. Their priority objective was to identify these potential funding sources to meet surveyed facility needs while identifying what is currently being allowed with the block grant. And surveyed facilities means they did an assessment and questioned and asked about needs in their state community. Progress was creatively considering block grant funding to compensate for the lack of coverage to Medicaid or alternative funding sources. And their lesson learned was that it is important to investigate all avenues of these alternative funding sources and additional resources instead of just depending on potentially what is used to, comfortable, and status quo, but to really think about some of these things creatively to ensure the most comprehensive coverage and support for those who need it, receiving maternal mental health services in the state of Montana. Any questions for Montana, like the states that we have here, you can feel free to ask them when we move on to the next portion, but we will be sure to get any questions for Montana to them after the fact, since they were not able to join us today. So thank you so much to all our presenting states. I had the opportunity to say it aloud to Teresa and Christine because I followed them, but we admire all of you and thank you for all of your efforts. It is time for some questions if we have them, and answers if we have them. Sometimes we reserve an answer for later on if we need that time. But using that Q&A box, please feel free to submit any questions you may have for our presenting states, and we will take them in if we have them live and in real time, moderate them with you, help pass them along. Again, anything that comes up for you after the fact, you can always feel free to submit to us through a number of channels, but we have some time for Q&A now. We do have a few questions that we received in advance of the session, and if we don't have any live questions, we can get to some of those as well. Seeing no live questions quite yet, I'll get it started and ask some of the ones we received in advance. They're pretty big questions, so any state can take the opportunity, if you're brave, to take a stab. But do you have an idea in your states of the percentage of persons receiving maternal mental health services that experience both issues with mental health and also substance use? And I'll open that up to any of our states who feel like to chime in. And if it's because we don't have exact percentages or figures, I get it. The answer probably is a lot if we're getting academic. But if there are any statistics related to that that you would like to share from your perspectives or your agencies after the fact, we can of course identify the person who asked that question and provide some additional context or information for them. Teresa, yes.
Sure. So, like I mentioned in our presentation, that we are doing some data pulls to get some information and gather. So I'd be happy to pass along any information that we get that would apply to that.
Great, thank you so much. Another big advanced question that we got, you saw my eyes getting big for that, don't get too nervous, which is what is your state's approach to address co-occurring mental health and substance use issues for persons receiving maternal mental health services? And how is this approached at the same time? Not a problem, folks. That's something else we can think about after the fact. I know a lot of you talked about the fact that some of you sit within the same divisions, some of you sit within very different ones and have the opportunity to now think about these things differently and not so siloed. You were probably thinking about that before. That's what brought you to this learning collaborative, but perhaps really honed and fine-tuned some of those approaches to collaborating across the comprehensive spectrum of services that we know needs to support persons receiving services for maternal mental health. So we can absolutely get back to the askers of those questions with some of that big data after the fact as well. Any other live questions from our audience? Okay, great. I will ask one question then of all of our states, and I'd love for each of you, whether it's one representative or both, to respond so that we can consider some priority areas and both potential opportunities for expanding upon this type of work moving forward. So the question I will ask is, if you had the opportunity to identify a priority topic for maternal mental health that would be the focus of if we had a next monthly session with this collaborative, what would that topic be?
I can jump in. This is Bridget from Connecticut. It might be a very specific to what we were working on, but I think it would be helpful to just get some best practice messaging on specific to, I think, the cultural piece. How do we communicate this information to various types of minority groups, even LGBTQIA folks, and wanting to make sure that we're doing everything best practice informed, making sure that it's effective, making sure that it resonates with folks, because I think that's something that I think for us specifically working in this would be super helpful.
Great, thanks, Bridget.
I think along the lines with that, engaging partners and community.
Great. All sound in their own way aligned with a lot of the key themes that came up at the beginning, right? These are things that we see throughout in a lot of this work, and maybe offshoots of or expansions on some of the things that we've already talked about within our collaborative, but important to expand upon.
This is Leah from Utah.
Yeah, great.
I will say we would love to, if we could have another session, we'd really want to focus on paternal mental health and the co-parent maternal or co-parent mental health.
Excellent, thank you.
Hi, it's Chris.
Great, Chris.
I'm thinking this at the next level because I have a feeling, a suspicion that the maternal mortality reports, the next go around, isn't that good. And I think that's significant. And what we need to do as states to improve. And actually, my other part of my role is I'm actually the president of the Women's Services Network across the country. But it sounds good, but it's, you know, it's just a title. But we had our annual meeting and we're really recognizing the impact of maternal mental health and SUD. And it is a priority. And I think we have a lot of work to do. And I think you had said something earlier, Leah, about working in silos. This has been a great experience for me and Suzanne, because it's interesting to hear what other states are doing, but I think we all need to move to the next step. And just listening, I was texting Suzanne because she oversees our block grant. We really need to make this for our states that get federal block grant funding for mental health and SUD. We need to put that in there. We need to have a plan. So that's my little piece of 2 cents, but I'm thinking strategically, you know, we have a lot of representation here and we really need to fine tune and what will our plans be as state government. So that's it. That was enough.
Thank you, Chris. And one last, not Chris, but Christine.
Yeah, so mine, if we had one more, what I would want to focus on is really, it's kind of a two-part, goes together, reducing stigma, but more concretely, looking at how as a state, when people come forward with perinatal mental health concerns and co-occurring concerns, there's a fear of not just stigma, but having your children taken away. And so how as a state, we can develop policies to make sure that that doesn't happen. So people will come forward to seek treatment and prevent those bad outcomes because they know that they will get help and support, not punishment by having your children taken away.
Thank you. Incredibly important. I asked this question not to give you a mini version of homework for our presenting states, or not homework, work right now for our presenting states, but to share with others in the audience here and those that may listen to this event after the fact, the things that you are thinking about in addition to the work that you're doing, ways in which other states, other territories, other localities may be thinking about some of the same things and might be able to connect on some of those things either organically amongst yourselves or if there's a way that we can help facilitate those connections. So thanks so much to the folks that offered your inputs and your answers, as well as to those of you just thinking about them. I know some of these morsels come after the fact, as we've all noted. Any questions that folks have, we'll move forward, but we still have a little bit of time. If you want to be sure to get them into the Q&A function, please feel free to, and we'll keep track of them during the remaining minutes that we have together, as well as after the event. I'll mention again, if any questions for expansion from Montana, we can absolutely get that information to them as well. But we'll move on from this Q&A portion now, as we only have about 15 minutes left with one another, and share just a couple closing pieces. Thanks again to everyone for your thoughts and contributions. Before we close, we wanted to be sure to share that, as with all SAMHSA Learning Collaboratives, there will be a summary maternal mental health learning collaborative resource document available to states, the audience members here, at a later date to be determined, but coming soon. This resource document will include an overview of the Learning Collaborative model and activities, summaries of all the subject matter expert presentations and related resources, and summaries of state case challenges as presented throughout our time together. So expanded upon a little bit more than the information that you heard during the time we have together for this webinar. So more information is to come on that. We'll keep in touch about it, and please be on the lookout. Next slide, please. In addition, states and territories can access state TA project services by emailing the state TA team at the email on the screen. To continue any requests for technical assistance or TA, please visit the secure web address on the screen as well. And key items needed to submit your request are a brief description of the technical assistance and the basis of the request. You must have an account to log in. Some of this may be familiar to some of you listening, but if you have any questions about it, you can send to the email there. All requests will then be reviewed by the Mental Health Block Grant Planner or SUPTR's Block Grant Coordinator State Mental Health Coordinator or SSA Director, SAMHSA Project Officer, and applicable SAMHSA leadership. It's a long list, but it's so that everybody's involved and looped in, and that there are broad perspectives incorporated. Once approved by the planner or the coordinator and the State Mental Health Agency or SSA, the SAMHSA State TA project team will follow up to set up a call to obtain more specifics about the request and to submit for SAMHSA approval. So in short, please know that additional tailored, targeted TA based on targeted needs that you have is available through the State TA project. Next slide, please. Lastly, we would like you to click the link in the chat, which was just entered there, or scan the QR code here. This is for audience members, does not need to be for our presenting states right now to open a survey about this event. This is anonymous and will provide SAMHSA with very valuable information about your experience today. So the link in the chat is active, or you can scan the QR code here. You can do that while you're still with us, or after you pop off. We'll leave that up there for just a second. And then we'll move on to the next slide in a minute because we also have the link in the chat. Great, thanks. I think we can move to the next slide. And I said lastly on the last slide, but no, wait, lastly now, thank you again, all. SAMHSA expresses their deep appreciation to the states and territories that participated in the Learning Collaborative and to those who presented at this webinar so thoughtfully, carefully, and beautifully, as well as thanks to all in attendance today. Wishing you a wonderful rest of your day. If you have no further questions, no questions to enter in the Q&A, no questions about the evaluation, and really hope that our paths cross again soon. Thank you so much, everyone. Have a good afternoon.